So I've been asked to talk about how to prepare proper visit summary or follow-up summary, discharge summary, and death summary. These are quite an interlinked. I'll try and um, address all three of these one by one. And in fact, some bit of it will be done in a rather common way. So, in a way, what I'm discussing today, or what the issues that have been asked, I've been asked to discuss. So, yeah. So essentially, what I have been asked to discuss today, it's all about the visible face of healthcare or medical care that you have delivered to a patient. This is what the patient takes back with him or her, and whether you like it or not, majority of patients cherish these documents provided by you, and they are shared widely. They are shared not just with healthcare workers, other doctors and nurses and pharmacies, but also shared like a trophy at times with relatives and friends. Oh, I got admitted, I was treated at such a hospital by so and so doctor, and here is the certificate of my treatment or discharge summary. So what I'm saying is there is a bit of importance attached to it, and there is a bit of kind of um, sense of pride attached to these documents, barring with the exception of death summary. Of course, you would not like to issue many death summaries, uh, especially not to patients who have been treated by you. So medical records, they are systematic documentation of the past and current information of a patient's medical conditions, the treatment the patient has received, and what have been the outcomes following their treatment. So the discharge summary, the follow-up or visit summary, and the death summary are vital components of medical records. And in a way, these discharge and death summary or case summaries are the visible face of the medical records. Of course, you can provide any number of other documents too to the patient or relatives, but primarily it is these summaries which are the visible face of patient's medical records, which the patient has in her own possession or his own possession. What is the need for preparing a discharge summary or a case or a visit summary or a follow-up summary? These are various documents, and as the name signify, these are somewhat different to each other. A discharge summary is when you are actually discharging a patient from your care, mostly from an inpatient setting, whereas a case summary or a visit summary or a follow-up summary is if the patient has visited you in the outpatient, or the patient has asked for a case summary for transferring to another patient, another doctor in another hospital, or else in case of follow-up summary, you have seen the patient during their ongoing treatment, and so you have needed to provide a follow-up summary. The need for these documents is to essentially to document the inpatient or outpatient treatment, investigations, and the progress record. And these are vital for ensuring continuity of care for an individual patient. These assist the ongoing treatment of a patient and assist in ascertaining the progress or deterioration of a patient during the course of the treatment or assessment. These are the documents which are going to be used by various other people, including the pharmacy, other physicians, paramedical teams, and who not, for knowing what the patient has been instructed, what has the prescription been, what drugs need to be dispensed, what investigations need to be done. These are all documented in your discharge summary or follow-up summary. And these also serve the purpose of documenting for posterity for use by other doctors within or outside the hospital, including perhaps yourself. You may see a patient 2 years, 3 years later, and then at a glance from the discharge or follow-up summary or visit summary, you can very well recollect what was the treatment or assessment or outcome of the patient in the previous visit. And these are also documents which are used by the patient herself or himself, the insurance companies, uh, or even the healthcare authorities or government authorities. What are the components of a visit or a follow-up or a discharge summary? It starts with the demographic data, the patient's name, the patient's husband's or father's name, the date of birth, the address, phone number, a case record number, for example, the CR number in SGPGI, but it may be called by various names in different hospital systems. And ideally, a unique identifier, which is, for example, the Aadhaar number or some sort of a social security number in certain countries, which can be used by anybody for ascertaining the identity of the patient whom we are talking about. It should also document the reason for visit or hospitalization. The patient may have visited just for getting a rather mundane thing, or for example, a medical certificate. But the patient may actually have visited for a deterioration in symptoms or a new symptom or new problem. And those things need to be documented accurately. Any significant findings on evaluation, on clinical examination, or the investigations carried out, the procedures and the treatment plan or provided during the course of treatment, during the current visit to the hospital, the condition of the patient at arrival or to the outpatient or at admission to the hospital, and at the end of the visit or during the discharge after completion of the hospital visit, the instructions that you want to hand out to the patient and to the family members. Okay, so, and then it must also have the attending physician's signature, the physician or surgeon or resident doctor's signatures, and legibly written name. A visit summary needs to be, or a discharge summary needs to be complete. It needs to be adequately extensive. It must document all the issues related to the clinical investigative diagnosis. Dr. Ashwath, can you please mute yourself? Ashwath S. This is the screen name of Ashwath S. The visit summary or the discharge summary needs to be complete, adequately extensive. It needs to document the issues related to the clinical and investigative diagnosis, the treatment, any referrals or consultations, cross consultations done. It should also document the treatment plan and the care that was given to the patient while the patient was admitted or while the patient was in the outpatient, with justification. Why was that needed? The operation or any procedures, interventions done, again with justification, the procedure performed, the lapses, if any adverse events or any complications, all those things must be documented. And finally, what was the outcome? Was the patient's condition improved at the end of the visit or procedure or treatment? Or did it remain unchanged, or the patient had a deterioration or an adverse outcome? So here, let me use an example. I'm sure all of you in working in this in the institute for a few months, or including maybe more than a year, have prepared some discharge summaries in this manner. And by default, the discharge summary you create brings up all these details: the patient's CR number, the name, the age as it has been calculated by the hospital information system, the department where the patient is being discharged from, the unit, bed numbers. These things may change. The patient may have been admitted in one location and consequently may have been shifted to another. And it would be a good idea because the automated system will only provide one location, one unit, and one bed number. But those details which you want to include, for example, the patient was initially admitted in cardiology and then shifted to cardiac surgery unit, all those things can be entered in the main editable field. The patient's admission number is automatically generated, the date and time of admission and discharge automatically put, whether the patient was a normal or a VIP or a research and referral system case. Those details can be generated based on the kind of admission performed, the consultant's name, discharge time, type, whether it was a discharge, regular discharge, discharge on request, or a LAMA, the patient's corresponding address has been recorded in the HIS during their registration. All these things are automatically generated. But mind you, as I'm sure many of you would have realized, many of these details are not accurate. They are not accurately recorded by the patient at the time of registration. And it would be a good idea to include those details in the editable portions of the discharge summary, because mind you, so often these documents are used and repeatedly used for various reasons, not just for care of the patient, but even for clinical research, data retrieval, and whatnot. And then underneath, you have to document. There are a number of departments where the units have number of consultants or faculty members. You may include the name of primary consultant, primary doctor. If there are number of doctors involved, you may write their names. The diagnosis, if a procedure was performed, what procedure was performed. Then a gist of the history, the clinic, the basic, the chief complaint, followed by things like what was the history of present illness, past history, personal history, family history, examination findings, etc. All these things must be included. One important thing that often gets ignored is it is best that you use your own login while preparing the discharge summary and while validating the discharge summary, because otherwise, if supposing the HIS, somebody else had logged in on the HIS and you started just using the same login, the records would show that the procedure, the discharge summary was prepared by another person, and that may create complications in later times. So these are the details, as I have explained to you, the demographic details, and I would like to re-emphasize that many times these are not complete, these are not accurate, and you may like to include the accurate, updated demographic details, including the primary care or referring doctor's name in proper areas, and if required, in rest of the editable areas. And these are the various components, including the diagnosis, the procedure or intervention performed, the chief complaints, present history, past history, family, personal, examination findings, anything which is relevant to the case. It is important to be concise, and it is best to itemize the description of the patient's initial presentation rather than being descriptive. A descriptive narration is difficult to comprehend for people who would use this later on. You must indicate the pre-existing conditions the patient arrived with versus the condition that those developed during the stay. And these are important because this would be a documentation of the progress the patient made during the hospital visit or during the treatment in the hospital. Examination findings, yet again, you need to be reasonably descriptive or detailed in what you found. The key investigation findings should also be listed. There is a whole list of investigation reports which are automatically generated to go with the discharge summary by the HIS, but there may be some investigations which are done outside of the hospital. The patient may have brought them together to the hospital with him or her, or there may have been some investigations which may not have been possible in the hospital on that particular day. So make sure those are listed in the discharge summary because they would otherwise not appear in the automated list of investigations. I think it is important, and I'm sure most of you would have that judgment to include only the significant and perhaps the abnormal laboratory or the radiological and other diagnostic results, rather than mentioning or listing each and every one of those. Then comes an important component of the course of treatment. The course of treatment, the nature of treatment, intervention, if any performed, and the details of those. Because otherwise, the patient, if the patient goes to a different doctor or a different hospital, these details would otherwise not be available to the new set of doctors who are going to treat the patient. And at the end of this, you must include a description about the patient's hospital course, what happened to the patient during the hospitalization, whether the patient was evaluated, prepared for an intervention or surgery or a treatment, what kind of treatment was done, what were the outcomes, was there any adverse event, etc. And you must include important developments while in the hospital, even though it must be emphasized that should not be over inclusive. The status at discharge is another important issue, and that must be included in the discharge summary. Next comes the section of advice on discharge. What kind of exercises or any activities the patient is advised, what kind of diet the patient is advised, what activities, daily activities the patient has been allowed or has been restricted, has been advised not to undertake, what medications the patient has been advised, and these include not just the new medication the patient may be advised while undergoing treatment at the hospital, but also must include all the other long ongoing treatment the patient may be taking, for example, the antihypertensive medications, anti-diabetic medications, etc. It is a good idea to itemize the list of medications, such as diabetes medications, blood pressure medications, and bronchial asthma medications, so that the patient can know at a glance that what all part of treatment has been advised. Most important, or rather very important component, is you must provide a clear instruction about which of the drugs or medications or means have to be stopped at a certain time. For example, an antibiotic, if prescribed, needs to be prescribed for a certain duration, whereas certain other medications like anti-diabetic or antihypertensives are to be written as continued till further advice. And there would be certain medications which can be advised SOS, for example, a pain medication or fever medication, and those things must be very clearly spelled out. The future plan is the next important component. The patient would require ongoing treatment. Many patients would require a second visit or a second set of treatment. Of course, there would be some who would not require any ongoing treatment, yet you would ask the patient to come in a follow-up for you to assess the outcomes and ensure there are no adverse outcomes or no need for ongoing treatment. All those instructions, including the instructions, how would the patient contact the hospital, which location in the hospital, that is OPD or the ward, in case there's a need for an emergency care, where the patient comes to. All those details must be spelled out and explained to the patient legibly in writing, as well as explained in the patient's own language before the patient is discharged. Yet again, it is best to provide an itemized follow-up instruction plan to the patient, and the recommendations for providers. Providers may be home providers, which are family members, or another hospital or a nursing home where the patient may be transferred to. And if any follow-up arrangements or referrals have to be done, again, they need to be listed very accurately and legibly. And these must be explained yet again to the patient and relatives. Do not leave out or do not miss out on the full name, the signature and date of the person who prepared the discharge summary. This is important because many times the patient himself or herself needs this information, and more often than not, it is the other doctors who treat the patient after you have who would require this information to talk to you because you have prepared the discharge summary and you would be knowledgeable about. So these are various physical components or various things that need to go into the discharge summaries, but all those things or a good discharge summary or a death summary would be possible only when you have the intention to provide a good or accurate or an ideal discharge summary. So the most important ingredient in my mind for preparing a good discharge summary is the intention to provide one. You need to have sufficient attention to details. These need to be individualized and should not just copy and paste from other documents. It is okay to use some templates, but again, very judiciously. They should not be done at its final level of just copying Ram Lal's discharge summary and giving it to Geeta Devi's relatives. Everything must be individualized. All the specifics in the discharge summary must be taken due consideration of given due consideration, and the discharge summary must be adequately detailed. All these things can be done only when you have allocated sufficient time to this activity. And one good way of doing this is do not prepare the discharge summary right at the time when the patient is about to be discharged. I'm sure you all know in the HIS there's a possibility to prepare a draft discharge summary, store it, and just before the patient is actually discharged, you can go back, retrieve that stored draft, make changes or edits, and then finally discharge the patient. So in summary, a discharge summary should have all these components which are listed here as a checklist. If you want, you can take a snapshot of this, keep for your ready perusal. The key elements to discharge summary are the problem that led to the hospitalization. Of course, it doesn't list the demographic details and those things which are given, but all these components must be there in the discharge summary. Problem that led to the hospitalization, key findings and test results, final diagnosis, the primary, the secondary diagnosis, and the underlying illnesses, if any, comorbidities, brief hospital course, condition at discharge, the discharge destination. More often than not, it would be a discharge to home, but at times it may be a discharge to another hospital or a nursing home. Medications advised at the time of discharge, follow-up appointments or proposed management plan in the hospital or elsewhere, anticipated problems which you may like to warn the patient about, and what suggested interventions you have in mind in case any of these problems do arise. The pending laboratory works and tests, for example, the patient has undergone a surgery for a tumor, final histology is yet awaited, you must include that. Recommendations for subsequent consultations or cross consultations, documentation of patient's education about the medical condition the patient has been treated for. For example, the patient is diabetic, the patient would have been advised how to check their own blood sugars, what to do about their diet, and then the food care and whatnot. All those things must be documented, and name and 24-hour phone number for the hospital and the physician records, because the patient may require an urgent care. The patient would also require follow-up care, and those things must always be listed here. So this is as far as the discharge summary is concerned. A death summary must have all the components that we have talked about so far in the discharge summary or death visit summary. But mind you, a death summary is a medical legal document. It must be prepared with utmost attention to details to ensure accuracy of the spellings of the patient's name, the patient's father's name or husband's name, all the address, Aadhaar number and phone number, etc. It must also have an accurate chronology of events. All those things which happened while the patient was in the hospital, or even before, including the date and time, because all these things have medical legal implications. And so please do pay attention to these details. The demographic details, as I talked about earlier, are a must. The medical conditions, the investigations, treatment which were meted out to the patient, and stepwise outcome. It is not sufficient to just write the patient died at the time and place or wherever. It is important that the patient had a long course of treatment. You must spell out the patient. For example, the patient had an extensive course of evaluation, investigations. The patient underwent, say, PTCA. The post-PTCA patient developed tamponade and whatever complications, and then what was done to take care of that. The patient may have been put on ventilator. Patient may have developed sepsis or multi-organ failure, and eventually the end point is death. So the deaths, oops. So the most important component of a death summary is the cause of death. This must be very carefully documented. The date, time, location of death, that is on what day, date, at what time of the day, and where. In the if it was in the hospital, must be written in the ICU or in the ward, in the operating room, wherever. It is essential to state the causes of death accurately and fully to the best of your knowledge and belief. This is perhaps your most important duty while preparing a death summary. Uh, these death certificates are the relative's permanent legal record of death, based on which a municipality or a registrar of deaths and births and deaths would issue certificates. This must include the accurate and the main causal sequence of conditions which led to death. In the first line or in the first part of the cause of death, you must state the direct cause of death which led to death of the patient. Merely saying cardiorespiratory arrest is not sufficient. You must work your way back through the antecedents of the condition in second line, and then until you reach the underlying cause of death, which initiated the whole chain of events which ultimately led to the death, which is the underlying cause of death, and that must be written in the end or in the lowermost line. It is best that you write them in 3 different lines. Different hospital systems and care providers have different ways of creating or preparing death summaries. It is best that you start with, as I've explained, what is the direct cause of death. For example, in this death summary, you can see rupture of myocardium. Why did the myocardium rupture? It was because of acute myocardial infarction. Why did the myocardial infarction occur? Because of an underlying coronary artery thrombosis, and that was caused by atherosclerotic coronary artery disease. If there are hints to or there are records to these things happening, and these must also be recorded in terms of chronology. So rupture of myocardium occurred at, say, let's say 12 noon on Thursday, the 12th of November, and the patient has been known to have had acute MI 1 week before presenting to the hospital, and the patient has been a known patient of coronary artery thrombosis disease or coronary artery disease for last 5 years, and has been known to have atherosclerosis or whatever other underlying causes for so many years. And it must also list the other comorbidities or the co-existing illnesses: diabetes, chronic obstructive pulmonary disease, tobacco usage, smoking, and all other things which can contribute to the patient's death. If you have information about any specific physiological or other components, if you have a suspicion of any foul play which would make this a medical legal condition, of course the death certificate has to be a medical legal certificate. It cannot be issued right away. If you think the patient requires an autopsy, that has to be arranged, in those cases, of course, the death certificates becomes a little more complex, and you need to take due care of all those. Another example: the patient may have died of acute renal failure. which has been there for the patient for a few days, but then the patient has been in some sort of a condition for a few weeks, and that condition which has existed for a few weeks was brought about because of an underlying condition, say for example diabetes mellitus, which was non-insulin dependent. And in this way, you must make sure that not just the direct cause, but the antecedent cause and the underlying cause are all listed in the death summary. So that is all that I wanted to discuss about the discharge summary, visit summary, and death summary. If there are any questions and comments, you're most welcome to